Good morning to our panel, distinguished guests, those joining us via the live stream, and those with us today in person. My name is Karen Peters, and I'm the UNODC Regional Drugs and Health Advisor. I'm also here on behalf of my UNAIDS colleague, Quintin Letea, and it is a pleasure to be the moderator for today's launch of the regional report on compulsory drug treatment and rehabilitation in East and Southeast Asia. This report forms part of a larger body of work which the UN began over 10 years ago. The first joint UN statement calling for the closure of compulsory drug treatment centers was released in 2012, followed by 3 regional intergovernmental consultations with countries mentioned in the report. The last statement was issued in 2020 in light of the COVID-19 pandemic and reiterated the UN commitment to support the closure and the end of compulsory facilities for people who use drugs. For those that are not familiar with this body of work, compulsory facilities for people who use drugs are a form of custodial confinement in which those perceived or known to be using drugs are forcibly placed to undergo abstinence and treatment for a predetermined period of time. Administered through criminal law, administrative law, or government policy, in East and Southeast Asia, compulsory facilities are operated by various government agencies, including the military, the police, the Ministry of Health, the Ministry of Social Affairs, or the national drug control agencies, depending on the country specific. Aiming for a drug-free environment, interventions are abstinence-based and generally restricted to detoxification, often are not medically supervised and provide little or no ongoing evidence-informed treatment, harm reduction services, or aftercare. Compulsory facilities for people who use drugs in East and Southeast Asia are a common phenomenon, and this report focuses on 9 countries in the region who use this approach: Cambodia, China, Indonesia, Laos, Malaysia, Myanmar, Philippines, Thailand, and Vietnam. The report we are launching today provides an update on the status of compulsory facilities in the region in relation to their commitments, these countries' commitments to transition. Allow me to introduce our panel today. First, we have Ms. Geeta Sabharwal, who is the UN Resident Coordinator in Thailand. With us in person is also Mr. Jeremy Douglas, the UNODC Regional Representative for Southeast Asia and the Pacific. Mr. Taufik Bakali, who is the UNAIDS Regional Director for Asia Pacific. With us online, we have Mr. Sam Nugraha, who is a member of the Asia Pacific Expert Advisory Group on Compulsory Facilities for People Who Use Drugs. Sam is also the founder of Ruma Singha Peka, which is a peer-led drug treatment organization. We have with us Ms. Rosma Karlina. She is the Women's Coordinator of Indonesian Act for Justice. She is also the Women and Harm Reduction International Network Chairperson for the Indonesia. We have from the Philippines, Ms. Nancy Jean Gacho, and Nancy is a paralegal at IDU Care Philippines. Last but not least, we have Dr. Claudia Stoicescu, who is joining us as the UNODC and UNAIDS consultant and the person who drafted the report. Without further ado, we're going to move on to the first presentation today by Geeta Sabharwal. Geeta was appointed as the United Nations Resident Coordinator in Thailand in March 2020 and has close to 3 decades of development experience working across multiple country contexts in Asia. Her work has focused specifically on peace building, governance, and social policy, while generating and applying empirical and big data analysis to deal with emerging development challenges. Geeta, the floor is yours.
Thanks, Karen, and good morning, colleagues, FCCT members, and distinguished guests. It's my pleasure to join you today for the launch of the regional report and to share ideas how we can work together to end compulsory drug treatment and rehabilitation in East and Southeast Asia. Thank you, FCCT, for hosting this discussion on an issue of such social importance. we can all learn from the experts here today sharing their insights. From the UN country team perspective, I want to cover how this important work is fundamental to UN's support for member states to progress the SDGs and the principles of leaving no one behind. Maintaining compulsory facilities in the name of drug treatment is simply not consistent with SDG 3 to ensure healthy lives and promote well-being for all at all ages, which underpins our collective work for sustainable development. I want to commend UNODC and UNAIDS for their collaboration on this report and their long-standing work on these issues. This kind of UN joint advocacy is crucial to address not only the health, but also social welfare and employment issues related to compulsory treatment and incarceration. Let's be honest in our assessment. There has been very little progress since the first UN joint statement calling for the closure of compulsory facilities 10 years ago. The narrative persists that people who use drugs and have drug disorders will be deterred by harsh punishment, despite abundant evidence to the contrary shown in overflowing prisons and treatment centers. We need fresh thinking based on best available data and evidence to break this pattern. This is why the joint report is important, to inform us, policymakers and the public about where countries stand on the path to permanently end compulsory treatment and rehabilitation. The goal is to support member states transition to voluntary community-based approaches encompassing elements such as harm reduction, mental health, social welfare services, housing, and employment. We also recognize the positive strides made by Thailand recently and its potential to be a regional leader with reforms that should lead to fewer people being imprisoned for personal drug use and possession and the abolishment of compulsory treatment. Now is the time to consider how we can build on these reforms and maximize positive outcomes for people and society. The report showcases examples of proven alternatives from across the region, often peer-based services run by civil society organizations, which member states can replicate and scale up for wider impact. These trailblazing civil society organizations should be commended, but services such as HIV prevention through harm reduction measures are still generally lacking, resulting in burdens on health system, reduced well-being and quality of life, and increased mortality. New approaches on voluntary treatment and care should accompany decriminalization of personal drug use as set forth in the UN System's 2018 Common Position on Drug Control, committing to alternatives to conviction and punishment in appropriate cases, including decriminalization of drug possession for personal use and to promote the principle of proportionality. This work is grounded in the principles of human rights and leaving no one behind that are fundamental to the UN mandate. In this spirit, I want to highlight UNODC and UNAIDS related work during the pandemic response, providing support and personal protective equipment to the most vulnerable, including people in prisons and those subject to stigma and discrimination. People who use drugs or who are in involuntary treatment or detention are members of our communities, deserving of the same rights afforded to the rest of us, and to be free of stigma and discrimination that harms their own well-being and that of society as a whole. The UN stands ready to support governments to align with international norms, standards, and conventions and end compulsory drug treatment. The evidence shows that legal, health, and social welfare systems that provide support instead of harsh punishment result in improved outcomes for us all. I look forward to further discussions and working together to move this issue forward in Thailand and the region. Thank you.
Thank you, Geeta. it's really important, the joint work of the UN in addressing this issue. And next up, to highlight this work, particularly from the part of UNODC, is Mr. Jeremy Douglas. Jeremy is the regional representative of the United Nations Office on Drugs and Crime for Southeast Asia and the Pacific, overseeing and managing operations and strategies from the Philippines to the Pacific in the areas of the rule of law, non-traditional security threats, law enforcement, criminal justice, and drug-related supply and health issues. Jeremy, the floor is yours.
Thank you, Karen. Yes, indeed, on behalf of UNODC, I'd like to acknowledge the FCCT and thank the FCT, as well as my good colleague Tofik, Quinton, UNAIDS colleagues, Claudia, the expert advisory group, and government and research partners for working with us on this important report. I also wish to acknowledge the leadership of Geeta and for her being here today, our resident coordinator in Thailand. She's been instrumental in promoting and supporting UN joint initiatives that bring our strengths together to help Thailand and the region address important societal challenges. The fact is, there are no easy or simple solutions to the regional drug problem. Production and trafficking have become more complex as the region has shifted away from opium and heroin to synthetic drugs. In recent years, supply levels have skyrocketed as incredibly powerful organized crime groups and their militia partners have scaled up production in the Golden Triangle. Precursors needed to produce powerful illicit drugs are easy to source, as are pre-precursors to produce them directly. Borders are porous, and the region's infrastructure is effectively being used for trafficking. On the other end of the business, where people are directly impacted, all governments are reporting rising and record drug use levels, particularly of methamphetamine. And prisons are extremely overcrowded, with up to 80% of inmates in some countries imprisoned for drug-related offenses. And while I could elaborate further, the point is there is no doubt the drug use issue is complex and requires an integrated policy response, although not every part of that response needs to be complicated. Adequate prevention messaging, voluntary treatment, and health services available at the community level. That is not complicated. Social inclusion and promoting health and well-being of people, including those on the margins of society, like drug users. That is not complicated. In fact, that is the core of the work we support as the UN and the Leave No One Behind agenda of the SDGs. And it is what the International Drug Control Conventions are meant to embody. I was personally in Manila in 2015 when 9 countries of this region, including Thailand, came together at senior official and technical levels to discuss moving away from compulsory drug treatment. That important meeting resulted in a renewed commitment to transition from compulsory treatment to voluntary treatment. The framework adopted then is comprised of 3 pillars. There needs to be carefully constructed interagency planning and management to meaningfully and finally end compulsory treatment, which in many places in reality is like a prison setting, as Karen has said. Second, legal and policy reforms need to be made to foster an enabling environment for meaningful treatment, reforms like Thailand has recently enacted. And that voluntary treatment can and should be strengthened by increasing health and community system financing. Unfortunately, the data we have found in our work with UNAIDS, and that is now being published, makes it clear that there is much to be done. Despite some positive examples and pilots, substantial progress has not been made in recent years. At the same time, it is clear that a balanced approach does not end with supply reduction, and support is needed to ensure that demand for drugs and the harms associated with drug use are addressed. This is crucial as it goes hand in hand with the commitment to close compulsory centers and move to voluntary treatment. But there are positives. We have tools that the international community, including this region, has agreed to, including those outlined in the UN General Assembly Special Session 2016 Outcome Document and the UN Common Position on Drug Control. We have excellent guidance documents, we have training curricula, and mentoring and capacity building efforts underway to support community-based services for people who use drugs, and we have support available for legal and policy reforms, as we have done here and in other parts of the region. The UN, government, academia, treatment experts, and civil society have also agreed that compulsory treatment should end. That commitment is there. In closing, change processes, especially those involving reforms of long-entrenched policy interests, are not easy. They take time. They take partnership. UNODC stands ready to support countries in their related efforts, along with my UN colleagues. Thank you.
Thank you, Jeremy. Indeed, I think we all need to come to the understanding that the time is now for this change to happen. We've been working on this advocacy for a while, which is why I'd like to introduce Taufik Bakali, our partner in this advocacy work over the past 10 years, is UNAIDS. Taufik is the Regional Director for UNAIDS Regional Support Team in Asia and the Pacific. He brings over 25 years of experience in development cooperation in health and education, including over 20 years working on strategy and evidence-based programming on health and HIV at global, regional, and country levels. Taufik, the floor is yours.
Thank you so much, Karen. Distinguished guests, ladies and gentlemen, dear colleagues and friends, thank you all for being here and joining us for the launch of this this regional report on compulsory drug treatment and rehabilitation in East and Southeast Asia. But first of all, I would like to acknowledge the excellent collaboration and partnership we have with UNODC on all areas of joint interest, not only this report, but much beyond, and also the valuable leadership of the resident coordinator in supporting the cross-UN collaboration and joint initiatives, particularly for progressing the SDGs and leaving no one behind. I would also like to thank the Regional Advisory Group and other experts, the government partners and community organizations for their contributions to produce this report. The data that will be presented today and as reflected in this report will show us that we need to do things differently. Mandatory detaining people in so-called drug treatment facilities is not effective. It also leads to grave human rights violations for the affected individuals and causes unnecessary costs to the society as a whole, particularly and including the ineffective health outcomes and the cost for running these centers. This report, in its 3 booklets, also does not only provide data on compulsory facilities for people who use drugs, but also elaborates on promising alternatives that do exist and do work and give results. It describes various examples of promising voluntary community-based treatment. The challenge is that these models are too often operate on a small scale. It is important that these initiatives get scaled up. From my perspective of UNAIDS, let me share 4 lessons from the HIV response with you, which are very pertinent to this situation, the topic of today. In my opinion, we can learn from these lessons in this context. First, the meaningful community involvement. Meaningful community involvement is key. Initiatives that involve peer-driven mentoring, education, counseling, and capacity building are essential elements for success. In the global HIV response, we talk more now about community leadership. Community leadership in decision-making, in service delivery, in service monitoring, and in processes that affect the population's lives. Several case examples in the report mentioned the role of people who with lived experience in the design, delivery, and monitoring of services. And those initiatives, just like in the HIV response, need to be adequately resourced, but more importantly, scaled up. The second element is criminalization. In most countries, people with lived experience cannot participate because of structural barriers. Like we see in the HIV response, criminalization does not work, and it leads to counterproductive results. It should be stopped. Drug dependence needs to be managed as a health and not as a criminal issue. This includes the decriminalization of drug use and possession for personal use. Criminalizing policies and punishments do not enhance public safety and security. Criminalization of drug use and possession is associated with numerous harms, including stigma and discrimination, criminal records that limit opportunities to access housing, education, and employment, as well as high-risk drug consumption patterns, overdosing, and the transmission of blood-borne diseases. The second element is stigma and discrimination. The criminalization of people finds its root causes in stigma and discrimination. It is a reality that PLHIV, people living with HIV, live, and key populations, including people who use drugs, that they face every day. Stigma and discrimination against people who use drugs are linked with decreased health care access and are influenced by public security approach to drug-related issues that promote coerced rehabilitation and punishment in many Asian countries. which leads to negative results and keep people further behind and excluded from accessing services. The fourth and last element I'd like to talk about is multi-sectoral collaboration and partnership, and we have excellent examples in this report reflected. The HIV movement has shown us that partnerships are crucial for success. Partnerships between different key population groups, between communities, between different sectors, between people living with HIV, governments, and scientists to know what works and what does not work. If different groups work together, they can achieve results. Multi-sector collaboration and partnership is also a critical requisite to facilitate policy shifts away from punishment and towards health-based approach to drugs. Ladies and gentlemen, a decade ago, commitments were made, but little was done. Now it is the time to do things differently. We have examples that work. Let us remember that these 4 lessons from the HIV response and finally transition away from the compulsory facilities for people who use drugs to voluntary community-based treatment. UNAIDS stands ready to support this process. Thank you so much.
Thank you so much, Taufik. Indeed, we do have really great examples from our region, which is why the next speaker is going to highlight some of these in her presentation. Dr. Claudia Stoichescu is a researcher and policy analyst with expertise in drug policy and HIV. She is associated with Columbia University's Social Intervention Group as a research fellow and consults regularly for United Nations organizations, including working with UNAIDS and UNODC for the past 2 years in relation to advancing community-based alternatives to compulsory treatment. Claudia is based in Jakarta, Indonesia. Claudia, over to you to present some of the key findings of the report for our audience members today.
Thanks, Karen. And thank you all for joining us for the launch of this joint UNAIDS and UNODC report, Compulsory Treatment and Rehabilitation in East and Southeast Asia. The use of compulsory detention for the purpose of drug treatment is a long-standing health and human rights concern, as you've heard from the previous speakers. For several decades, many countries in the region have operated compulsory facilities where people who use or are suspected of using drugs are detained, usually for the purpose of enforcing abstinence from drug use and treatment for drug dependence. Typically, it's a form of unconditional and forced custodial confinement administered with insufficient due process through either criminal or administrative law. The conditions of detention look different in each country, but a key shared concern is that people don't have a real choice to refuse treatment or to leave the program anytime without incurring penalty or punishment. In 2015, 9 East and Southeast Asian countries participated in a regional consultation on compulsory centers in Manila. These 9 countries committed to phase out compulsory treatment and rehabilitation. To do so, they adopted a roadmap for expanding voluntary community-based treatment and social services. The report findings I will present now assess progress on achieving these commitments and propose priority areas of action moving forward. Too often, punitive approaches are seen as a solution to ensure public safety and security. The reality is that this approach has not succeeded. Over the past 2 decades, the message from the United Nations, from civil society, and other experts has been clear. Compulsory detention should not have any role in the treatment of drug dependence. A wealth of evidence shows that compulsory treatment is ineffective in reducing drug use or treating drug use disorders. Compulsory detention fails to improve the health and quality of people detained, due in part to the lack of services to address the complex factors that may lead people to develop problematic drug use patterns. 2022 marks 10 years since 12 UN organizations released a joint statement condemning the continued use of compulsory treatment and calling on states to release detainees and replace these centers with voluntary evidence-based services. In June 2020, 13 UN agencies, organizations released a second joint statement citing concerns related to COVID-19 transmission in these centers due to overcrowding. The report we are issuing today is a renewed call to action. The message of the report is clear and simple. We must respond with united and decisive action to immediately and permanently do away with all forms of detention, coercion, and forced drug treatment. And we must, as a matter of urgency, scale up health-based approaches that are voluntary and that have proven positive results in keeping people alive, healthy, and thriving. The report consists of 3 separate booklets, the first of which is an executive summary outlining the key outcomes of the other 2. Booklet 2 is a regional overview of the issues of the status of compulsory treatment facilities using data provided or published by countries. We gathered these data through a questionnaire administered to health and drug control authorities in countries. In instances where data was not provided or was missing, we filled in gaps with published government data sets provided through official channels, such as the ASEAN Drug Monitoring Reports or government websites. Booklet 3 is a discussion paper developed in consultation with a group of academic, government, and civil society experts forming the Asia-Pacific Expert Advisory Group on Compulsory Facilities for People Who Use Drugs, which was established in 2020. This paper details case examples of promising practices from 8 countries that support the expansion of voluntary alternatives. Overall, political commitment to punitive practices in the name of drug dependence treatment continues across the region. All 9 countries that we looked at implement some form of compulsory treatment. The number of compulsory facilities, which is estimated at more than 800 in 7 countries with available data, has not changed substantially since 2012. In 5 countries, there was either an increase or no change in the number of compulsory centers, and only 2 countries registered a decrease. A similar picture emerges when we look at the number of people in compulsory treatment. Between 440,000 to 500,000 people were enrolled in compulsory treatment annually between 2012 and 2018. During this 6-year period, the number of people detained increased by 1%. 3 countries, China, Malaysia, and Vietnam, reported a decline in the number of people in compulsory treatment during this period, and 4 countries saw an increase, and those were Cambodia, Laos, Philippines, and Thailand. People were held in compulsory facilities for varying durations, ranging from 3 months to 2 years. And in most countries, methamphetamine was the most cited substance in relation to admission to compulsory treatment. It accounted for 50 to 97% of treatment admissions in Cambodia, Indonesia, Malaysia, Philippines, and Thailand. Across the region, compulsory facilities remain overwhelmingly run by the criminal justice system and are disproportionately staffed by security personnel, the military, or the police, which is more typical of a correctional facility than a health service. The visual on staff composition on the left, for example, shows that at least 50% of all staff in compulsory facilities in Malaysia and Cambodia were custodial staff, while a relative minority were medical and substance use specialists. This is deeply concerning. The UNODC and World Health Organization International Standards on Drug Use Disorders are clear that there should be no need for security and policing in the context of health services and drug treatment provision. On the right, the data points to massive overcrowding, with some centers operating at more than 400% overcapacity, which is a serious public health concern because overcrowding in closed settings poses a serious risk for HIV, viral hepatitis, tuberculosis, and now COVID-19 transmission as well. As of 2018, only centers in China and Malaysia were reported to operate below capacity. Compulsory centers typically aim for a drug-free environment. So interventions provided inside them are abstinence-based, typically monitored through urine drug testing, and often restricted to forced detoxification. Harm reduction interventions are lacking. These range from commonly understood measures such as opioid agonist therapy and condom access to pragmatic interventions like overdose prevention and management. While all of the countries answering the questionnaire state that compulsory facilities are drug-free, it is not uncommon for people to find a way of smuggling substances into closed settings. Due to this, promotion of the comprehensive package of harm reduction interventions is paramount to, at the very least, ensure the health and safety of people inside. Compulsory centers often entail numerous human rights violations. Lack of informed consent, exposure to violence, abuse, and forced labor, as well as the failure to provide evidence-based drug dependence treatment and health, harm reduction, and social support services lead to the violation of human rights, including fundamental rights, such as the right to life and freedom from torture or cruel, inhuman, or degrading treatment or punishment. Last year, the UN Working Group on Arbitrary Detention published a study that documented arbitrary arrest and detention without due process, punishment amounting to torture and ill treatment, solitary confinement, and in some cases, deaths due to severe beatings taking place in compulsory treatment settings in this region. We have very limited data for costs associated with compulsory treatment, but we can see from what is available that countries spend vast amounts of domestic funding on ineffective forms of treatment. An independent cost-effectiveness study showed that it cost Malaysia 2.5 times more to cover the annual cost of a person in compulsory treatment than the cost of a person accessing outpatient methadone during the same period. UN organizations developed international standards, and global experts are in consensus that what's needed instead of compulsory detention is a comprehensive menu of voluntary, accessible, and evidence-based treatment and care options. This has been referred to as community-based treatment and care services, and comprises, amongst other things, outpatient and take-home medication-assisted therapy, which may be opioid agonist treatment, but is not only limited to this. It also includes psychosocial interventions, needle and syringe programs, safer smoking kits, and provision of naloxone to reverse opioid overdose, among other evidence-based interventions. Also crucial and often neglected is the inclusion as part of this continuum of services that address people's welfare, economic, housing, and legal needs beyond just their drug use or HIV status. The model emphasizes that there is no one-size-fits-all service. Each individual with their intersectional needs should be at the center of a broad range of options, and treatment care plans should be tailored to those individual needs when and if a person seeks treatment free of coercion. This continuum of care does not need to be part of the criminal justice system, but rather should be easily accessible in the communities where people work, live, and use drugs. A key part of the third booklet of the report documents promising alternatives to compulsory treatment from 8 countries: China, Indonesia, Laos, Malaysia, Myanmar, Philippines, Thailand, and Vietnam. A selection of these are pictured on the slides. They include a program in Indonesia that is run by people with lived experience of drug use, providing harm reduction equipment and peer-to-peer mental health support to people using crystal meth. A voluntary community-based treatment initiative at a community hospital in Laos that was used as a model for scaling up the program to 28 other hospitals across the country, as well as case studies of partnership between the police, government, and community-based organizations to provide low-threshold take-home methadone in China and Malaysia. A common thread among these examples and the other examples featured in the report is the acknowledgement that many people may not be able to, nor desire to, stop using drugs altogether. And this was not a factor for punishing them or denying them access to healthcare. Effective models of care recognize that people experience different patterns of drug use influenced by many legal, policy, social, and economic determinants at different points in their lives, and they tailor their service provision accordingly. Unfortunately, availability and access to these alternatives is still insufficient, and many of these programs do not get scaled up. Many challenges are slowing down this progress. A key barrier is the ongoing criminalization of drug use and possession for personal use across the region. We know that punitive sanctions arising from criminalization, like mandatory urine testing, keeping registries of people who use drugs, and police surveillance, worsen stigma and discrimination and undermine access to health and social services. Since 2012, no country in the region has fully removed criminal penalties for drug use and possession for personal use. Whereas the UN system, as outlined in the 2018 UN Common Position on Drugs, promotes the decriminalization of drug possession for personal use, among other policy reforms that put people, health, and human rights at the center. The way forward proposed in this report is captured in the Regional Framework for Action on Transition, which provides a roadmap for governments to accelerate a paradigm shift from compulsory treatment, detention, and punishment towards health and rights-based approaches. The original framework was endorsed by countries in 2015 in Manila. It focuses on recommendations across 3 areas: enabling policy environments, planning and management of national multi-sectoral committees and action plans, and resourcing and strengthening health systems. In the report today, the Asia-Pacific Expert Advisory Group makes updated recommendations to strengthen the framework's 3 areas of action. An important proposed action is the removal of criminal penalties for the use and possession of scheduled drugs and other related offenses. This would provide the greatest potential benefit for people who use drugs, reduce overcrowding, and free up resources for more effective responses. Other key recommendations include applying the principle of proportionality in sentencing, prioritizing alternatives to conviction, detention, and punishment in places where drug use remains a criminal offense, and scaling up social welfare, economic, housing, and employment assistance to address the social determinants of health and drug use. These actions are vital if we want to reduce broader inequities and fight stigma and discrimination. The Expert Advisory Group also recommends reallocating funding that presently supports compulsory systems toward voluntary community-based services, including harm reduction. In closing, I would like to thank the many individuals who contributed to this report. I encourage you all to download the publication and have a read. Thank you for your attention.
Thank you, Claudia. That was really insightful and quite comprehensive, and we do encourage everyone to go onto the websites and download the reports. The QR codes will be shown at the end of this launch again for those that didn't catch it this time. Next, I would like to invite Sam Nugraha. Sam is an experienced drug treatment resource person. He is also a global trainer with the Colombo Plan Drug Advisory Program on the Universal Treatment Curriculum. Sam is a national trainer of the UNODC TreatNet Volume B and Family Interventions, and is a recovering person from drug use for 22 years. Sam, the floor is yours.
Thank you, Karen. Good day, distinguished guests and gentlemen and ladies. As you have heard from the introductions, I have experience in drug situations, personally and professionally. And what I would like to share, the journey to overcome the challenges for my personal has been quite supportive, especially from my family side. But back then, during the 90s, from the treatment side and from the policy side was not, I was lucky enough not to be affected like what happens on these days. I would like to give some more specific examples what I meant about the challenges. For instance, back then, during the 90s, the situations was the treatment has no specific standard like what we have at the moment, UNODC and WHO, and providing the international standard for treatment, even with the quality assurance. Back then, still on the trial and error. So what I would like to say, there is a many progress and improvement in certain ways. Therefore, in my personal experience, I would like to help other fellows who also having difficulties with the drug situations. So I developed this community-based treatment called Rumah Singgah Peka, which is a voluntary base and also integrated with harm reduction approaches, which is very humane, and the adherence for the clients to attend the sessions, it's much more high instead of the other facilities with compulsory approaches. And what I would like to say, the situations in my country specifically, even though the treatment more resourceful, the family need more support to provide support to their family members. The policy have potentials to work on both angles, whether helpful or harmful. So the situations is the product of different perspectives in dealing with drug use situations. One perspective is treatment and the other one is punishment. So I think we need to understand that even though there are many efforts to improve the situations in treatments, but the policymaker needs to understand both angles that I have mentioned. When is it going to increase more stigma, or is it going to increase law enforcement practices as a punitive approach, or actually is going to help people in treating people to overcome the challenges? And it is very important to put in place the evidence-based practice when we talk about treatment. In my country, the situation is concerning in terms of definitions of compulsory itself. More facilities are planned to be developed under the governments with one single methodology, the therapeutic community, which is the modalities actually is quite, we have a broad spectrums to approach with evidence basis. So I think this expert advisory group actually can play an important role to provide some data, some study, and come up with some recommendations, as Dr. Claudia has already mentioned, that I would like to restate it, the recommendations that we came in 3 major areas: the reform law, the first one, reform law and drugs to create policy environment that's supportive to human rights and evidence-based services. And I think this need to be followed up with more practical and tactical guidelines because policy is one thing that can cover many areas, but the translations into practice sometimes can differ to what it meant in the beginning. So I think the international agencies also can play a role to providing guidance or providing their expertise to support in development of practical guidelines and concrete. And the second one, I would like to highlight again about establishment of multi-sectoral committees and action plans in country that can be independently monitored and evaluated. I think this what I have mentioned in the first one a bit, and strengthen the existing community-based services. The situations about community-based services in the country is also concerning because I would like to reflect the quality assurance documents that UNODC have that mentioning about certain areas that need to be put in place in order to provide proper treatments that can increase a good quality and also the better outcome. In the country, usually is not adopting a complete tools or indicators. As you can also imagine, the outcome might be if we only use certain things, but not as a comprehensive approach. So again, I don't want to repeat everything what Dr. Claudia has already said. In the past 1 year, I have been involved in the expert advisory groups. Some of my friends even asked like, why you are working on compulsory right now? But actually what we are working on actually to improve the situations for a better result. And I would like to thank the other member of expert advisory groups. It's not just me, there are other countries like Thailand, Malaysia, Philippines, Vietnam also is there. Australia, that we're working really hard to provide feedback and to improve the drug treatment situations. Lastly, what I would like to say is basically the law. We need to change the law because sometimes it's translated really vaguely. For instance, in Indonesia, for considered definitions in the law, if you are an addict, then you will be sent to treatment. But if you are not yet an addict, they call it as drug abusers, then you can consider as a trafficker or that have a different penalty that can goes to the criminal sentence instead of treatment. So this is what I meant on the policy that needs to have a clear guidelines, because in practice, the situations can be more damaging from the intentions of that policy. Thank you very much for having me, and I will hand it back to Karen.
Thank you very much, Sam, for your intervention. And indeed, it is really crucial to have people who have lived experience of drug use to be able to support and implement interventions for people who use drugs. Speaking of laws and policies and change, I'm going to ask of Rosma Kalina. We have a video message that is pre-recorded from Rosma. She is the chairperson for the Indonesian board of the Women and Harm Reduction International Network. Rosma also serves as a coordinator for women and community empowerment at Indonesia Act for Justice, an organization that fights for access to justice and provides legal assistance for people who use drugs and other marginalized groups in Indonesia. Rosma is a recovering person from drug use for the past 13 years. Here is Rosma's message.
Drugs will be part of my life from the age of 12 and until 32 years old. My family sent me against my will to undergo drug treatment 17 times at all kinds of facilities, ranging from residential, rehabilitation center, psychiatric hospital, religious boarding school, and even spiritual and religious program. None of this was the right program to overcome my addiction to drug. At the time, it was very difficult to find rehabilitation for women, even though many treatment centers charged expensive monthly fees and my family was already spending too much money to treat my addiction. My time in treatment and rehab felt like a punishment for my drug use. Because my experience in the rehab center that I attended was very bad. It was inhuman. Most of the place I went to consider the drug dependence not a health issue, but thing related to the devil. It is still etched in my memory in one rehab place in West Kalimantan where my parents took me. There, they tied my hand and feet between two trees and chanted mantra as if there was a demon in my body that had to be expelled. The more I struggled to be free, and the more my hand would feel hurt and bleed. What I feel at the moment was anger toward everyone because they all punished me rather than trying to help me. In the past, I was often physically abused from my father because of my drug use. I also lost custody of my first child in the court at the time of my divorce from my ex-husband, also due to my drug use. Often labeled as cheap woman because of my drug use. I have also been dismissed from work because my company where I work discovered that I use drugs. Now it has been 13 years since I stopped using drugs. I did not stop through residential or type of forced rehabilitation, but because I was finally ready and want to recover. I joined a support group in the community where there was no coercions. When I first came to that place, I got tremendous support. They are listening to my story and keep my story only in that circle. There was no judgments or negative view toward me because they were my peer. They are also the same with me, having used drug before, so they understand my challenge is very well. In my view and experience, a good support system is what's really needed to manage drug dependence. Moral support and from family and the community is very important because someone come out of rehabilitation, they will return to the social life. And if the environment is punishing and judgmental, how can the person fully return to living and full life? Currently, as a paralegal worker for drug-related case, I witnessed a lot of extortion and violence perpetrated by law enforcement officers against people who use drugs, starting from arrest to imprisonment. Recently, many rehabilitation centers in Indonesia have been rebelled to collaborate with the police to extort people suspected of use drugs, detain them without suspicion evidence. Unfortunately, this punitive and corrupt practice tarnishes the name of other treatment and rehabilitation programs that provide evidence-based service. This situation also pushes people with drug dependence away from treatment and lower their trust in the treatment service. On behalf of my peers who use drugs throughout Indonesia, I ask government to take more human approach in dealing with people who use drugs. The government should guarantee the right and ease of access to range of service and treatment options that suit the needs of every person. Because not all people can be treated with the same method. If rehabilitation is right, then the state should provide effective rehabilitation services that are easily accessible, voluntary, compatible, free through health insurance or affordable. Thank you.
Thank you, Rosma. Apart from being a justice and legal rights advocate, Rosma is also a mom, and I think we could hear that in the video. You know, we appreciate working from home, and having to record video messages is not particularly always easy. Last but really not least, we have a message from Nancy Gacho. Nancy is 29 years old and from Cebu City, Philippines. She is a paralegal aid worker at IDU Care, a community-based organization supporting people who use drugs. Nancy will play that video message now. Thanks.
I'm Nancy Jane. I'm from Cebu City, Philippines. I'm now a paralegal aid worker at IDU Care, a community service, a community-based organization support people who use drugs. I also have lived experience using drugs. Being a sex worker and person living with HIV, I started using all kinds of drugs at 15 years old. From smoking marijuana, inhaling shabu, to taking syrup, to inject drugs, and even solvent. A few years ago, before I was paralegal works, I was employed as a HIV outreach worker and support group at the Cebu City Health Department. My peer and also my superior talks to me about enroll in outpatient private drug rehabilitation facility. Nalibog na ko. Out of respect my friends and superior, I said yes because it was on an outpatient visit. So I was enrolled in the drug rehabilitation program. At first, my experience in the facility involved a daily routine of everyday morning prayer, exercise, then take a bath, eating, the Narcotics Anonymous meeting in the morning and also in the afternoon. We started at 7 a.m. to 4 p.m. many weeks, but the cravings is still there because I go home, my enrollment is still doing drugs. Because I always violate rules in the facility, one day all my privileges were removed. The rehab center decided to stop allowing me to live and I become in-house patient. I was told supposedly for 6 months, but when 6 months passed, they still did not allow me to leave. I learned they will release me only if they have the consent order for my superior. I got angry because it's more than 6 months already. I become wild in the facility and finally let me free. When I was back to my place again, I began using drugs again and went back to my sex work. 6 months later, I was picked up again by the rehab staff and physically grabbed in the street to return to the rehab facility. It's like I'm arrested like a criminal. This is because they know I relapse and win the orders of my superior again. My experience inside the rehab is still the same as before. For 3 months as part of what was called the relapser program, I started every day inside the rehab with a morning prayer, exercise, and lots of NE meetings. After 3 months, I was released and went right back to using drugs. Overall, my experience in the rehab is from the start is not effective because first, in a way, I was forced my boss to go there at the rehab instead of being abstinent. I met lots of new drug users. In fact, I met my new boyfriends inside the facilities. In my opinion, in order to be effective and to recover from drug use, it has to come from me. There must be acceptance and willingness in me that I have a problem with my drug use. And only then I can seek support. Thank you.
Thank you, Nancy. Your story really highlights for us why we do the work that we do to try and advocate and ensure the closure of compulsory treatment centers. Colleagues, on the agenda we have next the question and answer session. We have some questions that have come through from the audience online, but if there are questions in the room, please feel free to let me know, and we can also give you the floor. The first question is for Geeta. Geeta, you mentioned in your remarks the new Thai Narcotics Code and how this abolishes compulsory treatment. What do you think is going to be key for Thailand in order to fully transition to a voluntary system of drug treatment?
Thanks, Karen. And I'm going to ask Jeremy to step in here as well. Just to reiterate, there are 2 points that I wanted to make.
Please.
On the new narcotics code for Thailand, it's very important to take note of the fact that this isn't being applied retroactively, which means that your compulsory facilities cannot be closed immediately. Right? There's a transition time, there's a lag time that we need to work towards. In terms of recommendations, and Jeremy, I'm going to depend on you on this, from where I sit, my own sense is it's very essential to create or to have enabling policies that are designed in a way that look at issues of the threshold amount for drug possession very, very smartly. Because if you set that threshold very low, you're going to have more and more people transitioning to treatment centers and prisons, which is exactly what you want to avoid.
Sure.
Right? But I want to bring in Jeremy here. Jeremy, you understand it much better than I. So what is it that you would recommend?
Well, I think you've hit the nail on the head, really, in terms of what is necessary immediately, which is this retroactive application. I think, we've had, the country has tens of thousands of people in these centers, and if they're going to cease to exist, we have to get the people out of those centers now. So that retroactive application has to happen. And I think the other point you made about the thresholds is also vital. For years, traffickers have had simply sometimes only a few yaba pills, tablets. And so people have ended up in prison or in these centers that clearly are not criminals, and because they've set the threshold incredibly low. At the border, it's only one pill, for transnational crime. So the point being, we need to set those thresholds correctly, properly. The other thing is really resources. If a small proportion of the resources that are expended in this country on law enforcement are expended on treatment, you can make a massive change. Right now, there's a very large national budget which is allocated towards enforcement and regional cooperation, which is appropriate at the right level. But the point is, if 5% of that could go into community-based treatment, 10% of that, you could have a massive difference in people's lives.
Excellent. Thanks, Jeremy and Geeta. The next question is for Taufik and Rosma, actually both of you together. The audience would like to know, specifically first for Taufik, right? UNAIDS puts a strong focus on community engagement in promoting the HIV response. And I think the listener appreciated your intervention on the lessons that can be learned from the HIV response. But what do we know about women in compulsory treatment? And what needs to be done there? And then I will ask Rosma the follow-up question. Rosma, the person also says, how do we reach out to women who use drugs to increase their access to health services? Because we know this group genuinely do not traditionally do so. So maybe we'll ask Taufik to answer first, and then I'll hand over to Rosma.
Thank you, Karen. A very pertinent question. But first of all, let me first acknowledge the very powerful and meaningful contribution of women in this event, as we see by the strong pertinence of the panel and their contribution and the moving stories we've just heard. Sometimes those human stories, even from one or two individuals, are more moving than numbers. The issue of data is well known, and we have discussed it also in the context of the World AIDS Day. Particularly for key populations and people who use drugs, there is a major discussion around the validity of the reported numbers. In general, for people who use drugs, there are in all countries almost serious discussions on whether the reported numbers are a good estimate or whether the real estimate is 3 or 4 or 5 times even higher. The reason for that is particularly stigma and discrimination. People go in hiding, and also criminalization. And it's not easy to have a good reporting on people who use drugs. Now, when it comes to women, the inequalities push the consideration of counting women even higher. And that's because there is a stronger level of stigma associated to women drug use. And we only go by global estimates that are based on some scientific, sometimes unscientific even, basis that tells us probably it could range from between a 2.5 to a 10% of all drug users, at least as we speak in a number of countries in the region. Now, the discussion when we talk about women in detention centers, that's even more difficult. We should normally be expecting that since this is based on service delivery, it's easy to just look at the record and get the numbers of how many women in detention centers. Unfortunately, we could not get these numbers for this report, and that's something we need to work on. But again, I would like to go back on the main point is when we do not have a number, human stories like we've just heard are extremely powerful, and I commend Rosma and Nancy for sharing with us their story, not only the suffering they have gone through, but also their learning that has led them to positions of leadership in advocating. So yes, numbers are powerful and help us to advocate and demonstrate and give the evidence. Human stories like this are also equally, if not even more powerful. We do not have the numbers, unfortunately, but that's something we would work on, and we work on the basis of the testimonies like what we've just heard.
Excellent. Thanks, Taufik. Indeed, that has been consistently the challenge when we collect the data from countries. There's simply no disaggregated data. Rosma, what advice can you give to service providers to increase the numbers of women that are accessing their services? How can we do things better?
Okay, thank you, Karen. Because the difficulty most often encountered by women who use drugs in accessing rehabilitation service so far is that there is not much rehabilitation that can accommodate women needs, because they may also a mother or even single mother who has to take care of her child, at the same time having to overcome her addiction. So, especially in my country, rehabilitation facilitated by the state is not much rehabilitation for women. So how come if you want to ask women who using drug to access the health service like rehabilitation, maybe better we all work together to change the method by their needs. Thank you.
Thanks, Rosma. That's really a key message there, including what you had also mentioned in your video around moral and social support. I think that is also really important for women who use drugs. This next question comes from the audience online again. Is for Dr. Claudia. In your presentation, you showed numbers of people in compulsory treatment, and you showed numbers of compulsory treatment centers increasing and decreasing. Do we have a reason for these fluctuations in numbers over the years?
Thank you for that question. Overall, the trends show that increases and decreases were relatively minimal, particularly in terms of the number of compulsory facilities. for the majority of countries, these numbers stayed the same or increased. And I would say that in terms of people entering facilities, there are many reasons that they may differ country by country. It may also be related to drug trends within that country, and different laws and policies and anti-drug campaigns that took place over the years that we looked at the data. I would probably say that, and I think here about the example of Malaysia. In Malaysia, we saw between 2010 and 2015 a strong commitment to transition away from compulsory treatment and toward voluntary community-based services, and strong political and financial commitment toward that transition. With a change in politics in recent years, that has changed, and we've seen that trend reversed. And I think this is quite similar to, it's really probably the one key reason, in my opinion, that explains many of the lack of change, I would say, ultimately the lack of change between 2012 to 2018 in many countries. It's political will and changes and laws, or lack of change, lack of reform, meaningful reform in terms of law and policy.
Thanks, Claudia. I think that summarizes well, but I'd also like to ask Taufik if you have any further points to add on this question from the part of UNAIDS' understanding.
Yeah, it's really a challenge that we see in almost all components, and we have the evidence that demonstrate that there is an issue here between the commitments made and how we see it translated into action. And usually there is a gap. We are seeing it here on people who are in detention centers. We have seen it as well in many aspects of the HIV response. I think there is some components that need to be looked at to link between the commitments, the political will, translation into policies, and into action. There is a gap in between, and in each country or in each situation, there is one piece falling off. Sometimes just because we do not have alternatives, or sometimes the alternatives are not scaled up enough to transition and make the numbers decreasing instead of increasing. It requires discussion more on a country-by-country basis, but the general observation is when we have seen several years ago, commitments made to close down compulsory detention centers, we still see that it does not translate. We cannot doubt the political commitment, but we need to look at why this political commitment did not translate and support that transition rather than look in the two ends of of the whole process.
Sure. Thanks, Taufik. I think that's really key, and it's also definitely one of my take-homes from what we've learned today. Lastly, there's a question for Sam and Jeremy. Both of you sound like you have a lot of experience working on drug policy from different perspectives. Sam from the community level and Jeremy from the UN policy level. Jeremy, you also speak a lot, and in your speech as well, about this balanced approach. What does this mean for you and for the UN's approach in the region? And then the question for Sam is, why do you think that drug policy reform is not happening so quickly in the region?
I think, mic working?
Yep.
Yes. Look, I think I'd like to build on what was just said by my colleagues and Taufik in particular. You know, the fact is that drug policy reforms, when you've enacted a power structure around policy frameworks and policy dynamics, paradigms for decades, it doesn't shift quickly and easily. And, you know, we've had a commitment made in this region to do this, but to follow that commitment with real political change is a massive challenge, because the governments of this region have constructed their drug policy framework through a public security lens. incredibly powerful parts of government control that power structure. They implement it, and they self-perpetuate that paradigm and that policy. So I think shifting from that to what we're describing needs to happen often doesn't take place. That shift doesn't take place unless there's a crisis or there's a radical change in thinking. And we haven't had, unfortunately, within the region, a lot of well-informed leadership on this topic. And we have had some glimpses, some hope. Here in Thailand, for example, I recall the minister 5-6 years ago really pushed things. Recently, the Minister of Justice here has really advanced the drug law change. And now, of course, we come to the point of implementation. So I think we really have to talk to the power structures in a different way, move them forward, and then provide that support that the UN can support, the UN can offer in terms of good policy advice and implementation. The other thing is data. I think fundamental to this on the policy side of things is just the poor data and or misinterpretation of the situation. And you hit the nail on the head, Tofik, when you said like stigma and criminalization of drugs really suppresses the data fundamentally, because people, you cannot gather good data from drug users in this region, and very few countries have estimates, if any, but then you can't survey the populations to understand what drug use is because of the stigma and criminalization. So a lot of the countries in this region have really, really low drug use estimates officially. So then, of course, that doesn't make any sense because we have this massive supply surge occurring. So you were right when you said the drug use levels are probably underestimated by 3, 4, 5 times. The drugs that are produced in this region are going somewhere. They're going into people. They're being used. They're being consumed. And I think the data don't match. And I think we have to have a big reflection on data development in this region so that we can then have a candid discussion with the policymakers and talk about what's necessary to address the situation. But they don't understand it. So that's a big challenge for this region is the data underpinning the reforms.
Thanks, Jeremy. Great intervention. Sam, do you have anything to add to what Jeremy said? Because I think you also echoed some of these points in your intervention earlier. Is there something that you particularly want to address on what can shift the drug policy changes here?
You mean politically or from community perspective?
Whichever perspective you'd like to focus on.
Okay, I think Jeremy has clearly mentions the complexity in moving forward the changes or the transitions, because it might involve the cross systems. For instance, like when we're talking about the treatment, and then mostly treatment falls under the Ministry of Health, and then the drug control usually dominated by the police force, and then it has a different standard policy implementations. That's another things that we need to work on when we specifically dealing with the same issues, or for instance, just specifically talking about the drug treatment services. It should be with the same language, whether is it from the police force or Ministry of Health, Ministry of Social Welfare, etc., etc. But this hasn't happened yet. They need to be facilitated. They have their own standard, they have their own understanding, and they have their own perspective. Some of them still think need to use punishment, and the other things need to be for the treatment. And that's the politically one. On the other hand, because the government, like Jeremy mentions, the power structures, I understand that in situations in Indonesia, the government has invested a lot to expand the government bodies and services and entities. So to shift that, first of all, changes is not easy. And when we come with the new approach, there will be a lot of reluctant or some, because they need to adapt with new things, and we might also consider if the person is not suitable to work on that area, then the person have to be considered where the government need to put the person or the government official. So the complexity is like that. I think to move forward, to fast forward, I think the government need to have a competitors in order to provide services in a healthy way. We mentioned UNODC have documents about community-based treatments, and government translate it in their own definitions. I think government need also to have a competitions from the community approach with a proper support from both angles. That way, from the government service and the community service are competing to have a better services. I think that might stimulate to speed up the transitions because we will have the data, we will show the improvement. Yeah, that's what I think on my personal opinion, that might increase, because right now the government doesn't have any other competitors, so business as usual. I think just following the policies and the regulations has already exists.
Sure. Thanks so much, Sam. Colleagues, we have come to the end of our launch this morning. We can download the reports via the QR codes, which we'll show in a minute. Please allow me to just summarize some of the really important and key points that we have discussed here today. The first mentioned by Geeta is that we need a joint and coordinated effort and regular data collection. This was re-emphasized that the decriminalization of possession for personal use of drugs will allow for the reduction of people in compulsory treatment and prisons, and the UN supports these efforts. Jeremy also mentioned that decriminalization actually, incidentally, will improve data collection. And I think that is a really important point to also reiterate. The only way to solve this complex issue is to implement simple solutions. And those are encompassed within voluntary community-based approaches. As Taufik mentioned, much can be learned from the HIV response, particularly around engaging the community or communities in finding the solution. Community interventions need support to survive, and I think that's what Sam mentioned in his intervention. To reach people who use drugs in a highly stigmatized environment, peer-based interventions are really key. And last but not least, we have to remember the people behind the numbers. And I think this is really the most important component. Our work is around promoting the Sustainable Development Goals and the rights of all human beings to the highest attainable standard of health. And that really improving or closing down compulsory treatment is going to help us to achieve those goals. I would like to thank a few people in closing. The first is Dr. Claudia Stoesescu for writing the report, the FCCT for hosting this event, Asia Works for supporting the broadcast, Quo for the design and layout of the publication, and the countries who provided data, least and not least those joining us in person, our panelists, and those joining us online. My name is Karen Peters. On behalf of UNODC and UNAIDS, thank you for your time.